Greetings. I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's September 2022 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. The editor's choice this month is an original article entitled Association of Self-Reported Walking Pace with Type 2 Diabetes Incidence in the UK Biobank Prospective Cohort Study. It is authored by Ms. Jirapichta Bonpour and colleagues from the University of Glasgow in Glasgow, United Kingdom, and the Catholic University del Mali in Tauca, Chile. Walking is both enjoyable and salutary. Indeed, there is a certain sense of collectedness, even cheerfulness, that comes from walking, derived either from the companionable engagement of accompanying family and friends, or when alone, from the unfettered and welcome opportunity to mull over the cares and concerns of the passing or the coming day. Walking is also salutary, as recognized as far back as the times of Hippocrates, who emphasized the pacifying effect of walking by opining, if you're in a bad mood, go for a walk. If you're still in a bad mood, go for another walk. Hippocrates regarded walking as the best medicine. However, as pointed out by the study of Bonpour et al. In the current issue of Mayo Clinic Proceedings, simply walking per se is not enough. These authors analyzed data from the UK Biobank Prospective Cohort Study that recruited more than 150,000 participants between 2006 and 2010. The rate of walking was categorized as slow, average, or brisk, and was self-reported. The median follow-up of participants was 7.4 years. The findings demonstrate that the risk for type 2 diabetes was higher in participants with an average walking pace, and especially so for individuals with a slow walking pace when compared with individuals with a brisk walking pace. This was true for both men and women. Additional analyses indicated that these associations were still significant when adjusted for various demographic factors, diet and lifestyle, adiposity, and overall physical activity. Furthermore, greater physical activity and longer walking time did not mitigate the increased overall risk for type 2 diabetes associated with slow walking. Finally, the analyses of Bonpour et al. Demonstrate that brisk walkers will exhibit an incidence rate of type 2 diabetes comparable to that exhibited by slow walkers, but remarkably, this is delayed in brisk walkers by approximately 19 years in women and 16 years in men. The authors discuss brisk walking as a lifestyle modification that may decrease the risk and delay the onset of type 2 diabetes, and the relevance of self-reported walking rate in risk prediction and stratification for type 2 diabetes. This important study supports the recognition by Hippocrates of the health benefits of walking, but this study emphasizes that at least for risk reduction for type 2 diabetes, walking needs to be done with brio and with briskness. Our first highlight this month includes a thematic review on perioperative medicine that is entitled Preoperative Management of Cardiovascular Medications, a Society for Perioperative Assessment and Quality Improvement consensus statement. It is authored by Dr. Sunil Sahai from the University of Texas Medical Branch at Galveston in Texas, and colleagues from several other national institutions. Cardiovascular medications are among the most commonly prescribed drugs, and thus an understanding of how these medications should be managed perioperatively is of considerable interest to many disciplines. This is particularly so as anesthesia itself may exert assorted cardiovascular effects. This article by Sahai et al. Provides evidence-based recommendations regarding the perioperative management of 21 classes of cardiovascular medications, focusing on those used in the management of hypertension, cardiac arrhythmias, ischemic heart disease, and heart failure. Not included in these guidelines are anticoagulant, antithrombotic, or antiplatelet medications, or medications employed in the management of dyslipidemia. To generate these guidelines, the executive leadership of this society selected 13 national experts from relevant and complementary disciplines to serve on a consensus committee. Using a modified Delphi process, the committee members undertook multiple Delphi rounds during an 18-month period of dialogue by teleconferences and emails. The process culminated in consensus regarding medication management and in the guidelines paper by Sahai et al. Notable considerations in developing these guidelines by this panel of national experts, including the following. First, the foundational concept of first doing no harm. Second, comprehensiveness in gathering and distilling the relevant and available literature, recognizing that in several instances, high-quality data are not available. And third, in-depth consideration of the pharmacologic actions and pharmacokinetics of the various drugs that are discussed. Discussion of each medication in the paper by Sahai et al. Concludes with a consensus recommendation whether to continue or to hold the medication on the morning of surgery. And a very helpful table in the paper distills the key considerations for each class of medications. For some classes of medications, a varied approach is recommended. For example, loop diuretics are generally held, whereas thiazide diuretics are continued on the morning of surgery. The authors also discussed the general conceptual approach as regards combination medications, polypharmacy, and minor procedures. Finally, the authors emphasize individualization of care by the managing team based on such considerations as, among others, the nature of the surgical procedure, the type of anesthesia, and the patient's coexisting medical conditions. Sahai and colleagues are to be commended for providing these instructive and helpful evidence-based recommendations on a topic of broad and timely interest. Our second highlight is an original article entitled Curbing the Delta Surge, Clinical Outcomes After Treatment with Bamlanivimab, Itazevimab, Casirivimab, Indivimab, or Sotrovimab for mild to moderate coronavirus disease 2019. It is authored by Dr. Raymond Razanable and colleagues from Mayo Clinic in Rochester, Minnesota. Surges during a pandemic are especially worrisome because they bespeak weakening containment and increasing infiltration of the infectious agent into the vulnerable population. In the fall of 2021, an overriding concern in this phase of the COVID-19 pandemic was a surge caused by the Delta variant, one due to the variant's transmissibility and pathogenicity. The study by Razanable and colleagues in this issue of Mayo Clinic Proceedings extends the series of contributions by this team of clinical scholars that has steadily and substantively illumined COVID-19 and relevant management strategies. Their current report presents clinical outcomes following treatment of high-risk patients with anti-spike neutralizing monoclonal antibodies during the period August 1, 2021 to December 1, 2021. This retrospective analysis involved more than 10,000 such patients treated with these anti-spike neutralizing monoclonal antibodies for mild to moderate COVID-19. The outcomes indicate that relatively few patients so treated exhibited disease progression to severe disease, as indicated by the need for hospitalization, oxygen supplementation, or death in the following 30 days after such therapy. Rates of admission to the ICU were similar among patients treated, irrespective of the type of treatment, and were 1% or less. A notable difference among the treatment groups was that rates of more severe outcomes were significantly higher for patients treated with casirivimab indivimab as compared with those treated with bamlanivimab, etesevimab, or sotrovimab, a finding for which the authors offer the quite plausible explanation that patients treated with casirivimab indivimab had a significantly lower rate of COVID-19 vaccination. Interestingly, in antibody-treated patients, all deaths occurred in unvaccinated patients, and unvaccinated patients were also overwhelmingly the ones in whom progression to more severe disease occurred. This important real-world study by Razanable et al. Underscores the efficacy of antibody treatment in high-risk patients in delaying the progression of mild to moderate COVID-19 to severe disease and the benefit derived from prior vaccination. You can access these highlights and editor's choice articles free of charge during the entire month of September. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the home page as well as through iTunes. You may also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.